Welcome back, everyone. Let's start with electrical pacing. Electrical pacing is used when the heart's natural electrical system is unable to maintain an adequate heart rate. The decision to implant a pacemaker is usually based on symptoms caused by bradyarrhythmias, or in patients with tachyarrhythmias who experience intermittent bradycardia that limits the use of rate-controlling medications. Pacemaker indications. The most common indication is sinus knot dysfunction, which causes symptomatic bradycardia. Patients often present with syncope, presyncope, dizziness, fatigue, or hemodynamic instability. Sinus knot dysfunction may result from age-related degeneration, fibrosis, ischemia, surgical trauma, autonomic nervous system disorders, medication effects. Another major indication is advanced atrioventricular block, particularly Mobitz type 2, second-degree AV block, and complete heart block, both of which usually require permanent pacing. Pacemaker complications. Complications may occur during implantation or afterward. Procedural complications include pneumothorax, hemothorax, ear embolism, lead perforation or malposition, pocket hematoma, infection. Less common complications include venous thrombosis, venous stenosis, tricuspid regurgitation, and lead-related problems. Device-specific complications include failure to pace, failure to sense, pulse generator malfunction, pacemaker syndrome, lead fractures, pacemaker-mediated tachycardia, which is generally benign and self-limited. Pacing techniques. Temporary pacing may be transvenous using the jugular, subclavian, or femoral vein, or transcutaneous, which is used in emergencies. Permanent pacemakers usually place leads in the right atrium, right ventricular, or both. Modern pacemakers may be single chamber, dual chamber, rate responsive, allowing heart rate adjustment according to physiological demand. Patients with heart failure and ventricular dysynchrony may benefit from biventricular pacing, also called cardiac resynchronization therapy, which stimulates both ventricles simultaneously. Implantable cardioverter defibrillators are life-saving devices designed to prevent sudden cardiac deaths. Most sudden cardiac deaths result from ventricular fibrillation, sometimes preceded by monomorphic or polymorphic ventricular tachycardia. ICDs continuously monitor the heart rhythm and rapidly terminate life-threatening ventricular arrhythmias by delivering either anti-tachycardia pacing or an electrical shock. Clinical trials have shown that ICDs provide a clear mortality benefit in secondary prevention after cardiac arrest or sustained ventricular tachycardia, and selected high-risk patients for primary prevention. Some patients with left bundle branch block, prolonged QRS duration, and left ventricular ejection fraction below 35% may benefit from cardiac resynchronization therapy with defibrillation, or CRTD, which combines biventricular pacing with ICD protection. Catheter ablation. Catheter ablation is a a minimally invasive procedure that treats treats arrhythmias by destroying abnormal electrical pathways responsible for the abnormal rhythm. Ablation modalities. The two main techniques are radiofrequency ablation and cryoablation. Radiofrequency ablation delivers high-frequency electrical energy that produces a small controlled areas of tissue necrosis approximately 5 to 7 millimeters in diameter and 3 to 5 millimeters deep. Cryoablation freezes the target tissue using temperature between minus 20 and minus 70 degrees Celsius. At minus 20 degrees, freezing is reversible, allowing electrophysiologists to test the effect before creating a permanent lesion. At minus 70 degrees, for approximately 5 minutes, permanent scar formation occurs. The major advantage of cryoablation is the ability to test the target safely before permanent ablation. Its main disadvantage is that it takes longer than radiofrequency ablation. Cryoablation is used most commonly for atrial fibrillation. Indication for catheter ablation. Catheter ablation is an essential treatment for several arrhythmias. For paroxysmal supraventricular tachycardia, the most common target is atrioventricular nodal reentrant tachycardia, where the slow AV nodal pathway is ablated. It is also highly effective for atrioventricular reentrant tachycardia caused by accessory pathways, such as in Wolff-Parkinson-White syndrome, where the accessory pathway is eliminated. For atrial flutter, the procedure interrupts the re-entry circuit in the right atrium. For atrial fibrillation, pulmonary vein isolation is the cornerstone of therapy, often combined with additional atrial ablation depending on patient's arrhythmia pattern. Catheter ablation is also used in idiopathic ventricular tachycardia, particularly when it originates from the right ventricular outflow tract or left ventricular outflow tract. In patients with a scar-related ventricular tachycardia using following myocardial infarction or cardiomyopathy, catheter ablation can reduce recurrent ventricular tachycardia and improve outcomes, especially in patients with amiodarone-resistant arrhythmias. To summarize, pacemakers are used to treat symptomatic bradyarrhythmias by maintaining an adequate heart rate. ICDs prevent sudden cardiac death by detecting and terminating life-threatening ventricular arrhythmias. Catheter ablation offers a curative treatment for many supraventricular and ventricular arrhythmias by eliminating the abnormal electrical circuits responsible for the arrhythmia. Now let's begin our discussion of ischemic heart disease, one of the most important topics in cardiology. Ischemic heart disease is the leading cause of cardiovascular morbidity and mortality worldwide, making it a major contributor to illness and death. Patients may be asymptomatic or present with symptoms such as chest pain or shortness of breath. It is important to remember that silent myocardial ischemia can occur without symptoms, but still significantly increases the risk of adverse cardiac event and cardiac death. Management focuses on optimal medical therapy, including controlling heart rate and blood pressure, reducing cardiovascular risk factors, and when indicated, myocardial revascularization with percutaneous coronary intervention or coronary artery bypass surgery. The primary mechanism responsible for ischemic heart disease are atherosclerosis and thrombosis. The disease is generally more common in men with a male to female ratio of about 2 to 1, although this difference decreases with the age. In women, the incidence rises sharply after menopause. The peak age of symptomatic disease is 50 to 60 years in men and 60 to 70 years in women. Now let's review pathophysiology of atherosclerosis. The process begins with the risk factors such as hypertension, diabetes mellitus, smoking, dyslipidemia, and chronic inflammatory conditions like rheumatoid arthritis. These factors cause endothelial injury, leading to increased permeability of the vessel wall and recruitment of inflammatory cells, particularly monocytes. Monocytes migrate into the arterial wall and differentiate into macrophages. Meanwhile, LDL cholesterol enters the vessel wall and becomes oxidized. Macrophages engulf this oxidized LDL through the scavenger receptors and transform into foam cell, creating the characteristic fatty streak, which represents the earliest visible atherosclerotic lesion. Sorry for that. As inflammation progresses, cytokines and growth factors stimulate smooth muscle cell migration and proliferation. These cells produce extracellular matrix, forming a fibrous cap over the lipid-rich core, resulting in an atherosclerotic plaque. The stability of this plaque depends on the balance between tissue repair and inflammation. If the plaque becomes unstable and ruptures, it exposes thrombogenic material to the bloodstream, leading to thrombose formation, which can acutely obstruct blood flow and cause myocardial infarction or stroke. Atherosclerotic plaques may also undergo several other changes. Classification increases arterial stiffness. Hemorrhage into the plaque causes further narrowing of the vessel lumen. Plaque fragmentation can produce emboli that travel downstream, while weakening of the vessel wall may eventually lead to aneurysm formation. Finally, let's discuss the risk factors for atherosclerotic heart disease. These are divided into non-modifiable and modifiable risk factors. Non-modifiable risk factors include increasing age, male sex, or postmenopausal female status, and a family history of premature myocardial infarction, particularly in a first-degree male relative younger than 55 years or a first-degree female relative younger than 65 years. Modifiable risk factors include hyperlipidemia, hypertension, diabetes mellitus, cigarette smoking, psychosocial stress, abdominal obesity, physical inactivity, heavy alcohol intake, poor consumption of fruits and vegetables, elevated lipoprotein, and hyperhomocystinemia. These modifiable factors account for more than 90% of myocardial infarctions, highlighting the importance of prevention through lifestyle modification and aggressive risk factors control. Several markers of disease can help identify patients at increased cardiovascular risk. These include high sensitivity C-reaction protein, coronary artery calcification, carotid intima media thickness or carotid plaque, and the ankle-brachial index. In summary, ischemic heart disease results primarily from atherosclerosis. Endothelial injury initiates plaque formation, which may progress to plaque rupture and thrombosis, causing acute coronary syndromes. Understanding the underlying pathophysiology and recognizing both modifiable and non-modifiable risk factors are essential for effective prevention, diagnosis, and management. In this page, we will discuss chronic stable angina, including its definition, pathophysiology, clinical presentation, assessment, and treatment. Chronic stable angina is a symptom complex caused by an imbalance between myocardial oxygen supply and myocardial oxygen demand. In most cases, this occurs because a fixed atherosclerotic plaque narrows a coronary artery, limiting blood flow during periods of increased cardiac workload. To understand stable angina, we need to consider the factors that reduce oxygen supply. These include narrowing of the coronary artery due to atherosclerosis or vasospasm, tachycardia, which shortens diastole and therefore coronary perfusion time, anemia resulting in reduced hemoglobin, hypoxemia with decreased oxygen saturation, and congenital coronary abnormalities. On the other hand, myocardial oxygen demand increases when the heart works harder. This occurs with tachycardia caused by hyperthyroidism, exercise, anemia, or pregnancy. Increased myocardial contractility, particularly in hyperthyroidism, and increased wall stress due to left ventricular hypertrophy or aortic stenosis also raise oxygen demand. Patients typically present with retrosternal chest pain, pressure, or tightness that may radiate to the left shoulder, arm, neck, jaw, or occasionally the right side. The pain is often associated with diaphoresis, nausea, or anxiety. A useful way to recognize classic stable angina is the 3 E's. It is triggered by exertion, can occur with emotional stress, and may be precipitated by eating. The discomfort usually lasts less than 10 to 15 minutes and is relieved by rest or nitroglycerin. If a patient meets only 2 of these typical features, the diagnosis is considered atypical or probable angina. If only 1 or none of these characteristics are present, the pain is classified as non-cardiac chest pain. Another classic finding is Levine sign, where the patient places a clenched fist over the sternum while describing the chest discomfort. Remember that ischemia does not always present with chest pain. Anginal equivalents include dyspnea, acute left ventricular failure, and flash pulmonary edema. Elderly patients, women, and patients with diabetes may also present atypically. Clinical assessment. Evaluation begins with a detailed history focusing on cardiovascular risk factors followed by a comprehensive physical examination. Laboratory investigations include complete blood count to detect anemia, fasting glucose and HbA1c to assess diabetes, fasting lipid profile, renal and liver function test, and thyroid function tests. A 12-lead ECG should be obtained at rest and if possible during an episode of chest pain. A chest X-ray is useful when heart failure, valvular disease, pericardial disease, aortic pathology, or pulmonary disease is suspected. Patients should then undergo stress testing to evaluate inducible ischemia. If indicated, coronary angiography provides definitive visualization of coronary arteries. An echocardiogram is useful to identify alternative causes of chest pain, including aortic dissection, valvular heart disease, hypertrophic cardiomyopathy, left ventricular systolic dysfunction or regional wall motion abnormalities, and precardial disease or precardial effusion. CCS, Functional Classification of Angina. The Canadian Cardiovascular Society classification grades symptoms according to activity limitation. Class 1, ordinary physical activity does not produce angina. Symptoms occur only with strenuous or prolonged exertion. Class 2, slight limitation of ordinary activity such as climbing more than one flight of stairs or walking more than 2 blocks. Class 3, marked limitation of ordinary activity. Angina develops after walking 1 or 2 blocks or climbing 1 flight of stairs. Class 4, angina occurs at rest or with any physical activity, making daily activities impossible without discomfort. Treatment of chronic stable angina. The primary goal of treatment are to reduce myocardial oxygen demand, improve oxygen supply, relieve symptoms, and prevent future cardiovascular events. The first step is general management, including lifestyle modification with smoking cessation, regular exercise, a heart-healthy diet, and weight control. Aggressive treatment of cardiovascular risk factors using statins, antihypertensive medications, and optimal diabetes management. Medical therapy aimed to stabilizing coronary plaques to reduce the risk of plaque rupture and thrombosis. Second, antiplatelet therapy. First-line therapy includes low-dose aspirin for most patients. Clopidogrel of aspirin is contraindicated. In selected high-risk patients, low-dose rivaroxaban combined with aspirin may be considered based on the COMPASS trial. Third, beta blockers. Beta blockers are the first-line anti-anginal drugs and improve survival in patients with hypertension and coronary heart disease. They work by reducing heart rate, myocardial contractility, and blood pressure, thereby lowering myocardial oxygen demand while increasing coronary perfusion during diastole. Cardioselective beta blockers such as metoprolol and atenolol are preferred because they produce fewer peripheral side effects. Agents with intrinsic symptomic activity such as acebutolol are generally avoided because they may increase myocardial oxygen demand. To summarize, chronic stable angina results from fixed coronary artery stenosis due to atherosclerosis. Symptoms are classically provoked by the 3 E's: exertion, emotion, and eating, and relieved by rest or nitroglycerin. Diagnosis relies on history, ECG, laboratory testing, stress testing, and selective coronary angiography. Initial management focuses on lifestyle modification, risk factor control, antiplatelet therapy, and beta blockers as first-line anti-anginal treatment. Finally, always assess symptoms severity using the Canadian Cardiovascular Society classification as it guides both prognosis and treatment decisions. Fourth is nitrates. Nitrates are primarily used for symptomatic relief of angina. Although they electively reduce chest pain, they have not been shown to improve survival. Their mechanism of action includes venodilation, which decreases preload and reduces myocardial oxygen demand. Mild arterial dilation, lowering afterload. Coronary artery dilation, improving myocardial blood flow. One important clinical point is that continuous nitrate exposure leads to tolerance, also known as tachyphylaxis. Therefore, patients should have a daily nitrate-free interval of approximately 10 to 12 hours to maintain drug effectiveness. Fifth is calcium channel blockers. Calcium channel blockers are usually considered second-line therapy or are combined with beta blockers when symptoms remain uncontrolled. They work by increasing coronary blood flow through vasodilation, lowering heart rate and myocardial contractility, therefore reducing oxygen demand, reducing blood pressure by decreasing afterload. However, there are important precautions as well. Non-dihydropyridine calcium channel blockers such as verapamil and diltiazem should be used cautiously with beta blockers because this combination may cause marked bradycardia or atrioventricular block. They are also contraindicated in patients with left ventricular systolic dysfunction because of their negative inotropic effects. Sixth is renin-angiotensin-aldosterone system blockade. ACE inhibitors are recommended for patients with angina who are at high cardiovascular risk, particularly those with hypertension, diabetes mellitus, proteinuria chronic kidney disease, previous myocardial infarction, or left ventricular systolic dysfunction. If a patient cannot tolerate an ACE inhibitor, an angiotensin receptor blocker or ARB is an appropriate alternative. Overall, RAAS blockade reduces long-term cardiovascular events and provides additional protection beyond symptom control. Seventh is invasive strategies. In invasive strategy, patients whose symptoms persist despite optimal medical therapy or those with high-risk coronary anatomy should be evaluated for coronary revascularization. Revascularization may be achieved by percutaneous coronary intervention or PCI using balloon angioplasty and stent placement. Coronary artery bypassing grafting or CABG is in selected patients. The choice depends on coronary anatomy, symptom severity, and overall clinical risk. Variant angina, Prinzmetal or Prinzmetal angina. Variant angina is caused by transient coronary artery vasospasm, which may occur when without significant atherosclerosis. Its characteristic features include episodes occurring between midnight and 8 a.m., chest pain that is not related to physical exertion, pain that responds rapidly to nitrates. During an attack, the ECG typically shows transient ST segment elevation. Diagnosis can occasionally be confirmed with provocative testing using vasoconstrictor agents, although this is rarely performed today. Treatment consists mainly of nitrates, calcium channel blockers. Patients should also receive strong counseling to stop smoking, since smoking is a major trigger for coronary vasospasm. Syndrome X, or microvascular angina. Some patients experience classic angina symptoms despite having normal coronary angiography. This condition, as syndrome X or microvascular angina, is believed to result from dysfunction of the small coronary resistance vessel. Patients may have positive exercise stress tests showing ischemia, normal epicardial coronary arteries. Fortunately, the prognosis is generally better than the obstructive coronary artery disease. Acute coronary syndrome, or ACS. Now let's move on to one of the most important emergencies in cardiology. Acute coronary syndrome, or ACS, represents a spectrum of conditions caused by acute reduction of coronary blood flow, leading to myocardial ischemia or infarction. ACS includes three major conditions: unstable angina, non-ST elevation myocardial infarction or NSTMI, ST elevation myocardial infarction or STMI. Distinguishing among these conditions is essential because their treatments differ significantly. Unstable angina. Unstable angina is diagnosed clinically and typically presents with one or more of the following: chest pain occurring more frequently, episodes lasting longer than before, pain occurring with minimal exertion or even at rest, new onset severe angina, angina developing after a recent myocardial infarction or following procedures such as PCI or CABG. Unlike myocardial infarction, cardiac biomarkers remain normal because myocardial necrosis has not yet occurred. Myocardial infarction. A myocardial infarction is diagnosed when there is evidence of myocardial necrosis, demonstrated by a rise and or fall of cardiac biomarkers, particularly cardiac troponin, together with at least one of the following: symptoms of myocardial ischemia, such as chest discomfort radiating to the arm, jaw, shoulder, or epigastrium, or shortness of breath; new ischemic ECG changes; development of pathological Q wave; imaging evidence of new loss of viable myocardium or regional wall motion abnormalities; identification of an intracoronary thrombose. If cardiac biomarkers are unavailable, compatible symptoms together with new ECG changes may still support the diagnosis. NSTMI versus STMI. NSTMI meets the criteria for myocardial infarction with ST segment elevation. STMI is characterized by a persistent ST segment elevation or a new left bundle branch block, indicating complete coronary artery occlusion that requires immediate perfusion therapy. The special populations. Remember that women, elderly patients, and individuals with diabetes often present with atypical symptoms. Instead of classic crushing chest pain, they may complain of shortness of breath, fatigue, weakness, nausea, or epigastric discomfort. These atypical presentations should never delay evaluation of ACS. Initial investigations when ACS is suspected. The first investigations include a focused history and physical examination, a 12-lead ECG obtained as early as possible, a chest X-ray to evaluate alternative diagnosis and identify complications such as heart failure. Keep in mind that up to 30% of myocardial infarctions may be silent or unrecognized, especially in women, patients with diabetes, the elderly, and heart transplant recipients due to cardiac denervation. To summarize, nitrates relieve angina symptoms but do not improve survival. Calcium channel blockers are useful when beta blockers are inadequate or contraindicated. ACE inhibitors or ARB reduce cardiovascular events in high-risk patients. Prince methyl angina results from coronary vasospasm and is treated with nitrates and calcium channel blockers. Acute coronary syndrome includes unstable angina, NSTMI, and STMI. STMI requires immediate reperfusion, while NSTMI and unstable angina requires prompt risk assessment and appropriate medical management. Always remember that women, diabetic patients, and elderly may present with atypical symptoms, making early recognition especially important. Thanks for attending. If you are new to the channel, please don't forget to like and subscribe and press the bell icon. See you in the next videos.